Hello, everyone. This is Dr. Siddharth, physician here at Chicago Arthritis and Regenerative Medicine. Welcome to our webinar today. Today, we are talking about regenerative medicine treatments. I'll be talking for roughly 20, 30 minutes. If you have questions, please put them into chat or into the Q&A section, and I will answer them either as we go along or at the end. I answer a lot of frequently asked questions as well. So what you will get from this webinar is the following. You'll learn about the best available treatments, non-surgical treatments for arthritis, tendinitis, injuries, and back pain that do not require surgery, including utilizing your own blood platelet treatments, stem cell treatments, what is legitimate in the field of regenerative medicine, and how to choose the best physicians and clinics for your regenerative medicine procedure. Again, if you have any questions after we're done, you can always reach us at chicagoarthritis.com. In the chat section, I've entered all the different ways that you can contact us, whether it's through our social sites, email, website, telephone, even scheduling directly into our scheduling software. So the big question is, what would you do if your pain was controlled? How would your life improve? What exercises would you restart? What activities with family and friends would you start to participate or re-participate in? So who am I? Just a little bit about me. My name is Siddharth, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, specialist in regenerative medicine, and image-guided musculoskeletal injections. In practice since 2008, involved in the regenerative medicine world since 2008, part of the Regenix network, which is the largest network of affiliated physicians in regenerative medicine since 2012 as well. So my personal journey into regenerative medicine, my own shoulder, I played a lot of tennis when I was a teenager. As I started to learn about diagnostic musculoskeletal ultrasound in my training, I started to realize I had my own sort of rotator cuff issues. I didn't actually have pain, but I had some instability issues. That got me started to thinking about tendon and ligament injuries a little bit more dynamically, which then got me interested in what other treatments are available, which then started with prolotherapy and platelet-rich plasma treatments, and then over incorporating other more advanced treatments like utilizing a person's own bone marrow stem cells. So why are we even talking about this? So the traditional care for tendinitis, tendon tears, sprains, strains, arthritis, joint pains, back and neck pains is really inadequate. You basically mask the pain and you wait for eventual surgery. The equivalent of that in, let's say, high blood pressure or diabetes care would be don't do anything until you've had your first heart attack or stroke. Nobody would do that nowadays. And yet that's still how the vast majority of medicine, traditional medicine, treats arthritis, tendinitis, injuries, and back pain. So there's a lot of problems with this. To begin with, pain medications, they certainly do not fix your problems. They can reduce your pain, but really don't fix the source of what's going on. Some of the more traditional injections, whether you're talking about steroid injections or nerve blocks, radiofrequency ablation, they can give you temporary pain relief, but they have side effects. Steroid injections can have not only damage your local tissue, increasing infection risk, but also have a lot of metabolic issues if you do it too often and too frequently. Nerve blocks and radiofrequency ablation actually damage the nerves, which can then lead to muscle weakness. So there's a lot of issues with these kind of treatments. So other problems with surgery, surgery has a role in things that are more severe. But for things that are moderate or mild, the thing is that it's higher risk in terms of bleeding, infection, tissue damage, anesthesia risk. If you're cutting out tissue and you're not replacing it, you're just accelerating the arthritis process. So it leads to more instability, and routine surgeries like knee arthroscopy in the setting of wear and tear arthritis are not recommended any longer because they're no better than just doing physical therapy because they cause too many other long-term problems. And for those of us involved in regenerative medicine, really strongly feel like eventually 80% of MSK conditions can avoid surgery. So in searching for better options, we need options that are low risk, avoid serious side effects. They should address the source of the problem. The source of the problem for most musculoskeletal issues are either instability or inflammation and metabolic issues, frequently a combination of these two things. So what we want are treatments that actually improve the cause of the problem and give you a long-term improvement as well. So imagine reducing your pain and getting back to activities you care about without surgery or pain medications. Yes, yeah, I see some questions popping up. I'll start to get to those as time goes on. I'll answer some of these as we go on. Thank you. So regenerative medicine is a process of utilizing your body's own cells to treat your arthritis, tendinitis, injuries, and back pain. In a normal healing process, let's say you have a cut on your finger, something mild. What happens is that you have platelets that come into the area, they stop the bleeding first, they then release growth factors, which then stimulate your local cells, your local stem cells to start a normal healing process. That involves inflammation, it involves bringing in other cells, and there's a slow cellular repair process that works well in tissue that has good blood supply, like muscles and skin. For tissues with poor blood flow, they tend not to heal as well on their own. For example, tendon, cartilage, ligaments, discs, labrum, and menisci. Those tissues are hardy, but once they've been recurrently injured or just over time from a prior injury, they can then lead to chronic instability, which then puts more stress on the joint, arthritis, and then there's sort of a cascade of problems. So regenerative medicine is the process of taking those same cells, your platelets and your bone marrow stem cells, and then inject them under high-level ultrasound and X-ray guidance into the area where the tissue is damaged to coordinate that normal healing process in tissue that's already been damaged. And so even if we cannot fully repair tissue that's been damaged, we can optimize that tissue so that it's more stable and strong, so it's less inflamed over time, which are the two things that drive your pain and dysfunction and arthritic issues, so that we can help to optimize the tissue so that you have less pain, better function, and hopefully also prevent this from accelerating and progressing over time. So why regenerative medicine? You're treating the source of the problem, which is instability, different than surgery, affect most musculoskeletal conditions, and again, likely appropriate for most 80% of things that are currently going for orthopedic surgery. So as I mentioned, regenerative medicine works by optimizing damaged cells, improving strength and stability of your supporting structures, reducing chronic inflammation. And we also treat the neuromuscular areas around the joint to help heal those issues as well. It's a very busy slide, but really what makes a regenerative medicine expert, this is something you want to be thinking as a patient. There's a lot involved here, but this is important for you to really choose the right person as your physician. Your physician, if they're treating you for your joint issues, they have to be a musculoskeletal expert. And what that means is they're focused on musculoskeletal issues, arthritis, tendinitis, injuries, and back pain. If they're treating diabetes in one room, erectile dysfunction in another room, they're giving Botox in another room, that's not a musculoskeletal expert. That's someone who's kind of dabbling in a lot of different things. They should be a non-surgical MSK expert. Our surgery colleagues, orthopedic surgeons, are great surgical experts. They generally do not have certain skills when it comes to the non-surgical aspect, things like image guidance when it comes to doing treatments. The problem if you don't use image guidance with these kind of treatments is that these treatments, you have to hit exactly where the tissue is damaged very precisely, down to the sub-millimeter level. I'll show some examples of that. And you need the right kind of training with ultrasound and X-ray guidance to do that exactly. Number 4, they need to understand how to use inflammation to help you heal. See some of my pain management colleagues who'll be giving steroid injections kind of willy-nilly, not understanding that that is counterproductive to the regenerative medicine treatments. Number 5, they need to understand the different types of biologic treatments that you use so that they can give you a personalized treatment plan versus a one-size-fits-all. I have colleagues that just give the same treatment to everyone every single time, not understanding that things have to be really personalized to your particular issues, whether it's arthritis, whether it's tendinitis. I'll give some examples of that later on. They need to understand the concept of prolotherapy and how to treat instability. I see a lot of physicians who do these treatments where if you've got arthritis, they're only injecting into the joint. They're not treating all the other supportive structures. That really leads to a better outcome long-term. They need to be transparent regarding your results, potential results, and your candidacy for treatment. If they're not really understanding this properly, they're not guiding you through this properly. You should follow your results long-term, right? These are slow-acting and progressive improvements. It should not just be they do a procedure and don't see you again. And they should really guide you through the process because these treatments are relatively new. Patients have questions, and they should be able to guide you through this in an expert manner. So some other kind of basics to understand. Is this legal? Absolutely. There are definitely strict guidelines from the FDA, including Cells that are taken out need to be prepped and re-injected in 1 day, cannot be over time. Number two, we're only treating musculoskeletal issues, arthritis, tendinitis, injuries, and back pain. You should not be treating things like strokes and autism and cardiac issues and kidney issues. Those are not legal under the FDA guidelines. And then lastly, you need to make sure you're not mixing in anything else that the FDA considers inappropriate. People who are doing fat stem cells, they mix in some other things that are considered questionable by the FDA. And actually, the last one is also that you need to be using your own cells, not somebody else's. All right. In this country, that's pretty standardized at this point, but there are people who go to other places in the world where that's not. Another common question is, if you're older, shouldn't you be using someone else's cells? No. Orthopedic conditions, there's good evidence that using your own, everything that we treat, with one exception, age is over 65, that can make worse out difference. Now, it would be great if we were all 25 years old. Reality is that youth is king, and the way someone who's 18 to 30 years old heals is better than someone who's older. But when you look at the data for folks who are older, they still do pretty well with treatment, and so there is no age limit to these treatments, the one exception being your hips. What sort of doctor does these treatments? I mentioned all the things that your physician needs to be an expert in this. Can these treatments help if you've already had surgery? If you've had like knee arthroscopy, shoulder arthroscopy, yes. If you've had back surgery, yes. If you've had full joint replacement, we're not really treating the metal or the prosthesis at that point. That's kind of a separate issue. But as long as you haven't had kind of metal put in, you're okay to get these treatments. My general rules for guidance for my patients, if they're considering orthopedic surgery, is try to keep your own anatomy if possible. Avoid surgeries that are just cutting out tissue, which is most knee arthroscopy surgeries. And always consider a regenerative medicine treatment option if you've been recommended surgery to see if you're actually a candidate. Just before we go on, let me just take a look at some of the questions that have popped up. All right, somebody asking, they have reactive arthritis due to long COVID. Okay, so this is more a question about someone who's got chronic inflammation and interested in, I think, rheumatoid arthritis medications. A little bit off base for what we're talking today. I think I probably have some content on our social sites where I discuss that. But perhaps email us separately, and maybe that's something that we can discuss offline. But that's not exactly kind of what we're talking about today. Okay, so kind of get back at it. So we're talking about some regenerative medicine key concepts. The first is the concept of stability and prolotherapy. Stability is very key. There's this concept in architecture called tensegrity. That means is that if you take individual units that are weak on their own, but if you put them closely approximated together and compress them, you have an overall structure that's much stronger. In medicine or biology, that's called biotensegrity. So prolotherapy is this concept that if you inject your own cells into those soft tissue supportive structures that surround the joint, you get progressive strengthening and stabilization of the joint. The keys are to treat all the different layers and depth of that structure, that overall unit that needs to be treated. You'll get a progressive strengthening over time, which gives longer lasting improvements with treatment as well over time. Very key aspect of regenerative medicine. It's a case study of a 71-year-old man, chronic lower back pain after 2 surgeries, very common thing that we see, failed lower back surgeries. Treated every layer that's causing problems, ligaments, facet joints, muscles, and epidural space. Initially just using platelet-rich plasma. He had 30% pain improvement, which was good for him, but aiming for better results. We escalated to using his own bone marrow stem cells, got him to a 75% improvement. The keys here are treating every level that's driving the issue. And in this case, not just injecting into the epidural space, but injecting all those other supportive structures. That's what's really given him benefit. Despite the fact that he's failed surgery times 2, it's that you treat the full comprehensive unit. Next key thing to understand is orthobiologics. These are the biologic cells and tissues that we inject into damaged orthopedic tissue. mentioned, we use a normal healing process. Use your own cells, not somebody else's. That's really where almost all the data is in the literature, by using your own living cells. Safer, less risky, and still effective. Platelets are really that first line orthobiologic treatment. Again, platelets work because they recruit other cells and stimulate your stem cells. They use focus inflammation to repair tissue damage. There's a couple different types of platelets that we actually use. There's using your own high concentration of platelets, and then there's using platelet lysate, where we just take the growth factors from the platelets. Platelet-rich plasma is great for tendons and joints. Platelet lysate is better for nerves. It's less inflammatory, better for nerves and ligaments. The way that we do this is we do a blood draw from you, centrifuge it multiple times to concentrate it into a high concentration of platelets. In general, the higher your concentration of platelet-rich plasma, the better it is for joints and tendons. For ligaments, you generally want a lower dosage. You need to vary the dosage based on what the issue is. If you have a one-size-fits-all kind of dosage, it's a problem because you're not going to get the ideal outcome. So the picture on the right is of platelets, two different types of platelets. The one on the left that's amber or yellow colored, we've taken out all the red blood cells, less inflammatory. That's really what you want to inject into joints and tendons. The one on the right has more red blood cells. It's more inflammatory. Generally, we don't use that, but that can be more helpful for muscle issues. So when you're getting your treatment, you want to see that you're getting a platelet-rich plasma that looks more like the amber-colored one there. It's a case study for an individual with knee tendinitis treated with platelet-rich plasma. 45-year-old man, a cyclist, referred to me by a sports medicine physician because he had recurrent and persistent pain despite physical therapy and other conservative options. So the picture on the right is of a ultrasound picture of a patellar tendon that shows some chronic changes. This is an individual that got treated 2 times over about 6 months. The picture on the right is an ultrasound image showing the needle injecting into the patellar tendon itself. He did great. Essentially, he returned to his full activity, full capacity, really almost all his pain gone. Did really well with that treatment for his left knee. We ended up treating his right hamstring, his other leg, 3 years later, when he'd strained the other tendon. In that case, platelet-rich plasma, 1 treatment, doing great, back to full activity. What's nice about this case is this is a great example of where platelets work really well as a first-line option for a lot of issues, especially for tendon injuries. In addition, how repeat treatment is helpful and how treating another injury down the line can also be very helpful as well. Next type of orthobiologic to understand are your own stem cells. Your mesenchymal stem cells are the main cell that drives tissue repair and recovery after an injury. Again, please use your own cells, not somebody else's. In the United States, bone marrow-derived stem cells are what's legal. Nothing else is. Fat stem cells are technically not legal in the US. You can use fat or adipose for structural support, let's say in a rotator cuff issue, but the enzyme that's needed to break down the adipose to get a high concentrate of your own stem cells, that is considered illegal in the US. You may have heard about amniotic or umbilical cord cells. There's no living cells in that. I haven't written this one down, but there are other products that you may hear that are kind of similar to that nowadays, amniotic umbilical cord cells. These are just growth factor treatments. There's no living cells into that. These are not stem cell treatments. The FDA has started to clamp down on clinics that are sort of presenting those as something that they're not. IV stem cells, not something you'll see in the United States, something you may see outside of the US. No proven benefit for orthopedic conditions. I know people that are using it for a lot of other things, may have some other benefits, but strictly for your own joint or tendon issues, I would stick with treating the exact joint and tendon directly. The problem with IV stem cells is that once you put it back into your bloodstream, as it travels through the heart and the lungs, they tend to get caught up in the lung tissue. And so you don't actually get the full kind of joint benefit that you would expect if you're injecting it directly in there. So some other common questions that I get, we certainly can improve pain and function even in advanced cases. So if you have advanced arthritis, you can definitely get improvement in your pain and function. Can we improve your X-ray and MRI images? If you've got advanced arthritis, I can't get your X-ray or MRI to look like what it was 10, 25 years ago. That's just not possible. If you've got a tendon tear or ligament tear and it's less than 2 centimeters, we can absolutely still actually improve the imaging on those. I have some pictures of that. We can also improve the swelling that you see in a joint, in an arthritic joint, or in the bone itself. I'll show some pictures of that. And we can also treat a condition called avascular necrosis as well. So can we treat bone-on-bone arthritis? And this term bone-on-bone arthritis is one that physicians use a lot, and it's really not accurate. As an example, if your physician says that you've got bone-on-bone arthritis in the knee, and yet you're still able to flex your knee, it doesn't really make sense, right? Like you still have a cartilage interface there. So the key thing to understand is that arthritis is a biologic condition that's treatable with orthobiologic treatments. If your range of motion and function are still intact, good outcomes are still possible. Arthritis is a biologic condition. It's not just an X-ray picture that you put up on the wall. An X-ray picture that you put up on the wall is technology from, 70 to 80 years ago. All right, it's not modern day technology, and our understanding of arthritis is a lot more nuanced than just how do the bones look on a static image. Some caveats when it comes to advanced arthritis. Hip osteoarthritis is challenging if you've got more advanced arthritis. However, understand that if you've got advanced arthritis for other joints, pain and functional improvement is still very likely, even if improving your imaging is not likely. And that's because we're treating the actual biologic condition of arthritis, instability and inflammation. We're not just treating what the picture looks like. Let me just quickly take a look to see if there's any other questions. All right, somebody asking about hips. Yeah, so what I'm saying about hips is that the data that we have for hips says that if you've got advanced arthritis of the hips, it's harder to get a good outcome. All right. We also know that if your age is over 65, harder to get a good outcome with hip arthritis. Other joints, age and degree of arthritis does not matter. And so if you've got significant arthritis in the hips and you're over the age of 65, I would generally refer people for hip replacement surgery at that point. If you've got lesser degree of hip arthritis, still something that is treatable. Somebody asking about spinal stenosis causing pain in sciatica. Yes, absolutely. We use platelets for that, generally speaking, all the time. Great option. The keys there are to treat all the ligaments that are involved. There's a number of ligaments overlying the spine that really, if they get irritated and hypertrophied just because of chronic irritation and inflammation, that's what leads to that spinal stenosis. And if you can strengthen those ligaments and the other supporting ligaments, you can take some of that pressure off the nerves and actually reduce not only pain, but your sciatica symptoms as well. So definitely something that we can treat. It's a good question. Someone else asking about torn meniscus. Yep, commonly that's something that we treat all the time. So for sure, something that should be considered for non-surgical treatment. The problem with most meniscus surgeries is that normally when they do a meniscus surgery, they cut out the meniscus. And the problem with that is the normal stress that you have going through and force going through, let's say, it's still going through the knee, but now you've lost that normal supportive structure, that normal meniscus that's there to support the knee. And so you're more likely to progress to more progressive arthritis. So if it's possible to keep the meniscus and the tissue there, you should absolutely do that because it will make a difference. Okay, good questions. Just kind of jump back to it. All right, so this is a case of, so can we treat tendon and ligament tears? Certainly, I said that, and I said that they can also improve how your imaging looks. So this is an example of a gentleman, 28-year-old man. He's a butcher. He's a regular guy. Participating in recreational volleyball, had a tear back in 2017 while playing recreational volleyball. We treated him a couple months later with his own bone marrow stem cells. By December, he had no pain, restarting dynamic exercise. What's really exciting is his imaging results. So The image on the right is an X-ray image of a knee. You'll see the needle that's going into the knee, and what's lighting up there is actually the ACL. Important to understand that you can do these treatments under very high-level image guidance. The key is that you have to have an expertise in that kind of technique. And if you do, you can make a dramatic improvement in how people do, not only in terms of pain and function, but even in terms of the actual integrity of the ligament itself. So in this case, there's a pre-treatment MRI and a post-treatment MRI. And I apologize, I do not have my cursor to help point this out right now. But the pre-treatment MRI on the left side shows an MRI, shows a ligament that is hazy and torn. The radiologist has initially called that a possible full thickness tear, or at least a partial thickness tear. The image on the right, the ACL, is completely normal looking and completely linear looking as well. And the radiologist has read that as now a healed and normal ACL. So an exciting result in a knee case and something that we're able to do. This is a 57-year-old man with a full thickness rotator cuff tear. He's a general contractor, does a lot of overhead activity. We utilize his own bone marrow concentrate stem cells. The ultrasounds on the left side are his pre-treatment ultrasound, literally a hole in the tendon. What you see on the right side is much better. And now you see tissue that's completely filled in where that black hole previously was, just showing that we're healing the actual tissue. I actually saw him recently for his shoulder again. This is now like 7 years later. And he had kind of tweaked his shoulder again with his work. And the tendon is still intact. There's a little bit of chronic irritation to the tendon, so we're going to treat that again. But that prior tear is still doing very well. This concept of interventional orthopedics is really another key thing to understand. It's a concept of using image guidance to treat orthopedic injuries. This ultrasound picture on the left is of a rotator cuff tear. What's listed as supraspinatus tendon is the rotator cuff tendon. The needle, you see that kind of line going in there. There's a little black space where the needle tip is injecting into the rotator cuff tendon. This is obviously a very zoomed up picture. And the key thing to understand is that we're injecting here into a space that is less than 1 millimeter by 1 millimeter. To do that accurately, you have to use image guidance, and that's how you get a good result. This is an image on another shoulder treatment. This is a shoulder. There's the line of the needle there. You'll see a black sort of curved line. That's how we confirm that we're injecting into the joint. We put a little bit of contrast into the joint, and then we inject your own cells there. You'll also see a little triangular structure that's outlined there. That's the labrum. This is someone also has a labral tear. To inject that blindly is essentially impossible. And to do that under X-ray or ultrasound guidance is critical. And in his case, that's how we're able to get a good result. I showed these pictures before. Ultrasound picture on the left is of injecting into a patellar tendon, precisely where the tendon has its damage. The picture on the right is of an X-ray image of injecting into the ACL. Again, that's a deep structure into the knee. To do that properly, you have to be using X-ray guidance, not even ultrasound guidance. Next case study is of a 41-year-old man. He's a chef standing on his feet for 10 to 13 hours every day. Ridiculous. So he, not surprisingly, developed left ankle pain. And what he's found to have is osteoarthritis, chronic inflammation, and avascular necrosis. Avascular necrosis is basically where the bone starts to die. All right. And so he ended up getting stem cell treatment protocol. His pre-treatment MRI on the left side shows a talus bone that has a lot of swelling and essentially avascular necrosis, dying bone in there. If we don't treat that, what will happen is that this bone will continue to degenerate, and eventually the cartilage will degenerate, and he'll just be in a terrible position. He would need a replacement. So we inject it into the joint, the ligaments, and into the bone. His post-treatment MRI is doing great at that stage. And really even more exciting is that the prior stress in the bone has now completely resolved. The white structures in the bone has completely resolved. So not only a great Clinical result in terms of pain and function, he's back to full-time work, standing on his feet as a chef all day long, all night long, but also a great MRI result as well. Regenerative medicine treatments offer safe and effective solutions for your pain. Please give me a moment as I kind of catch up on some questions here. Somebody asking, can you have this procedure if you just had a steroid in your right knee? What I recommend is if you've just had a steroid injection, wait a month to get that out of your joint. The reason why is because if you're getting a very low dose of a steroid injection, that's okay. But most physicians, when they're injecting steroids, they use a dosage. It's prepackaged in the vials at a super physiologic dose. It's at a dosage that is over a million times what your body would normally be exposed to. And so that will block the effectiveness of any of the regenerative medicine treatments. So I would recommend getting that treatment, orthobiologic treatment, at least a month after your steroid injection. Okay, somebody else mentioning quad tendon rupture in 2018, still having pain, kneecap not aligned correctly in X-ray causing clicking and pain. Yeah, so you've got chronic instability for sure. We'd have to look at the imaging. How does that look? How does the tendon look? Decide if you're better off using your own blood platelets or bone marrow stem cells. If you had a full-on quad tendon rupture, you probably would do better off with your own bone marrow stem cells. The keys there are to treat not only the quad tendon, but if you now chronically have some instability in the patella, the quad tendon inserts onto the kneecap, right? And if the quad tendon is weakened from that prior injury, then the kneecap itself will be a little bit unstable. That's what's calling the misalignment, which will then cause arthritis in the knee joint, pain in the knee joint as well. And so the key is to treat not only the quad tendon, but the ligaments around the knee joint and then even into the knee joint itself. So that is depending on the status. Like if your tendon is ruptured again and fully pulled apart, then that's a different story. But if the tendon is still relatively intact, but just sort of beat up, then that's still something we can definitely treat. Yep, question about cost, and I'll get to that in a moment. Okay, all good questions. Right, and again, if you have any other questions after we're done today, please go to chicagoarthritis.com. So is this too good to be true? Yes, it's an interesting thing. I have colleagues who, because I've been doing this since 2008, I have colleagues who 5 years, let's say 10 years ago, were saying that they thought that regenerative medicine was bogus. They really didn't know any of the data. 5 years ago, they were saying, maybe there's something there, but they weren't sure. And now they'll tell you they utilize regenerative medicine, although they're still not sure how well it works. And it's kind of a problem because if you're ignorant to what's available, then it's hard to really give an expert opinion. But here's where the data sits, right? There's data originally from Philip Hernigue, probably really the first physician that I know of that was utilizing regenerative medicine in terms of bone marrow and platelets. There are folks who've been using dextrose prolotherapy, which is like an earlier version of regenerative medicine. That is still a good option for some people. That's been going on for decades, 50 plus years, 60 years. Philip Hernigue is a French surgeon that's been using bone marrow and platelets since the 1990s. He has studies where he compares a patient that got surgery in one shoulder versus stem cells in the other shoulder, or knee replacement in one knee and stem cells in the other knee. So he's got a very interesting cohort of patients showing the success of regenerative medicine treatments in 2005. So, this is a field that's rapidly developing. It's definitely not new. Again, I have personal experience since 2008. There are right ways and wrong ways to do this for sure. And your expectations, at least your physician, when they're explaining expectations, should be grounded in reality and evidence-based medicine. Should not be pie in the sky, should not be like magic pixie dust. It really should be based on what we know we can really do. How long do results last? Look, there's data that Philip Hernigue that goes over 20 years. Regenix has data that's over 15 years. What I tell people is think conservatively. If you have a chronic condition, like if you've had arthritis in the knee for 30 years, expect that if we do a bone marrow stem cell treatment, that you'll likely need either a booster platelet treatment sometime in the next 5 years. If you have more advanced arthritis, you may need a repeat booster platelet treatment at the 1 or 2 year mark. If you've got a mild to moderate condition and we're treating that with platelets, expect that you may need a repeat treatment 2 to 5 years down the line as well. I think that's being conservative, but realistic and sort of reasonable as well. I think the best ways to maintain your results after treatment: improve your biomechanics, work with physical therapy, for example, use the appropriate joint supplements that help with pain and inflammation. Repeat treatment can be additive to initial treatment if needed, meaning that you get an improvement initially, you stay at that higher level, and if you do a second treatment, you're not kind of building off that level, you're kind of stair-stepping higher. Maintain your ideal body weight to reduce stress on the lower back and legs, improve your metabolic health and inflammation, which is a part of the arthritis process. So much so that we've actually started our own weight loss program to help people who need that to help with their metabolic health and their arthritis as well. In terms of cost, these are not routinely covered by insurance. The exceptions are if you are one of the 2,500 to 3,000 companies in this country that are self-insured that have added the Regenix benefits to their plan. To learn more about that, you can go to regenixcorporate.com. It's an incredible plan, quite frankly, that actually covers these treatments. Otherwise, the cost estimates in the US are really as follows. Dextrose prolotherapy will cost you about $700, PRP $2,500 plus, and using your own bone marrow stem cells about $7,000 plus. Keys to determine value are: number one, make sure your physician and clinic are regenerative medicine experts. Make sure that you're receiving a real stem cell treatment, not something that's been mislabeled. And then lastly, these are in-office procedures. You can avoid hospital and surgery center fees. Went through what makes really a regenerative medicine expert. It's a lot of different things. In medicine, to be an expert, you have to be like deeply focused on something. And to do it right, you have to go 100%. You can't go 50%, 80%, 90%. You have to go 100%. And this is really what it takes to be an expert in this field as well. A little bit about how we do things here at Chicago Arthritis and Regenerative Medicine. Focus on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain. Evaluating you for inflammation, instability, asymmetry, neuromuscular issues. Correcting with low-risk interventions if possible. If that's not working and you've got something that can be treated with a regenerative medicine approach, we then consider that. Utilizing the best quality products from your own body, plan that's tailored to your condition specifically, and delivering those cells using the highest level of image guidance possible. If interested in evaluation, you can either go to the website, chicagoarthritis.com. In our chat section, you'll see a few different ways. You can call us, you can email us, you can go directly to the website. You can even directly through that link that's listed on number 3, schedule directly into our clinic as well. And we're here to help, answer questions, and help you in any way possible. See a few more questions. Somebody asking about severe osteoarthritis in the right knee, 63 years old. Not a candidate for knee replacement because their leg's been broken and overweight. Yeah, that is a little bit more complicated, asking about insurance, asking about kind of payment options. We always have payment options to help finance things for folks. Also keep in mind that there are different levels of treatment. So, what takes one bone marrow treatment will take 2 to 3 platelet treatments. What takes 1 platelet treatment takes about 3 to 4 prolotherapy treatments. And so there's always options if needed. And certainly we're able to help people out with financing strategies as well. Okay, somebody else asking, it looks like these are just asked before I kind of mentioned the cost and insurance aspects. Not generally covered by most commercial insurances and Medicare. Again, if you have self-insured company, if you work for an employer that is self-insured, you're actually able to add these to your benefit plan as well. Regenixcorporate.com can help talk you through that as well. Wonderful. Well, I appreciate everybody's time today. Before we wrap it up, if there's any last questions, please let me know. Wonderful. I don't see any other questions on our social sites as well. But otherwise, I appreciate everybody's time today. And if we can be of additional help, please contact us. Somebody asking, are the slides available? So we'll make the replay of the webinar available. You'll get a link for that. You can watch that anytime you want. You can share that with friends, family, and colleagues if needed as well, so that you can review this at your convenience. Wonderful. Well, thank you everyone for your time. And until we connect again, hope you all stay healthy and well and live well. Bye-bye.